Aris has been introduced already, so I won't say much, except that he's the director of fetal medicine and the clinical research director. Importantly, he has done multiple trials, including all types, epidemiology, and has co-founded the Oxford University spin-out Intelligent Ultrasound. A little while ago, we heard from another academic turned entrepreneur how this is critical if you want democratization, and Aris, I'm wonderful to see you're doing this. And to give the balanced perspective for the real world, we also have Dr. Angela Koech, who's an assistant professor for the Department of Obgyn and co-PI for the PRECISE project at Center of Excellence in Women and Child Health, Aga Khan University. She's a medical doctor with training in epidemiology, 7 years experience in clinical research and medicine for maternal newborn health, has set up several clinical studies, as well as the most real world thing that gets a perinatal surveillance program at the KEMRI Wellcome Trust Research Program in Kenya. A proper surveillance program in the field gives you the most relevant experience. She will come in the middle, and I think let's, without keeping you from the main speakers, Ari, please go ahead and take over the floor.
Thank you so much. Can we have the slides, please? So my brief is really to talk to you a little bit about some of the real world implementation of some of the tools that we've been hearing about. And is that movable? No, like that. Okay. Can we start the slides, please? It's been really wonderful, a really wonderful meeting, and so nice to have engineers in the room together with clinicians, industry. And I'll say, while we're waiting for the slides to come up, in terms of declaration of interest, like Ashok, I fully agree. My declaration of interest statement is very long because I've worked with all the ultrasound companies very closely to bring some of these solutions and to also to understand the need. So it's talking really a little bit again about ultrasound. Apologies to the speaker who was talking about ultrasound, there being more than ultrasound, but because our work is focused on maternal and child health, most of what we do, especially in obstetrics, is ultrasound based. This is my declaration of interest statement. I do work for intelligent ultrasound, but there's nothing here of any commercial sensitivity that I will be showing. I just want to start with some basic concepts, really, and I'm not going to go deep into the methodology of AI because you're more expert in that than I, except to say that we all know the power of this tool in day-to-day, whether we're driving to the airport or getting in a plane, or indeed admiring the nature of the place and wanting to count objects in space, or perhaps a little more sinisterly, surveillance of the population. But how can we apply some of these concepts to medicine? AI in medical imaging is dependent on a whole number of things, but one of the big things it depends on is data. And we've heard a lot about data and how important data are to driving these solutions. Just look at that slide of digital data that are available in healthcare. I keep this as a reminder for me to remind me what a zettabyte is. I've just come to terms with lakhs and crore here in India, but these are zettabytes of data. 40 zettabytes of data, of digital data, were available in healthcare settings in 2020. It's estimated that we use between 2 and 5% of that for real world solutions. So one of the challenges that we really need to think about is how we increase and make use of this powerful availability of data. We'll be talking about ultrasound, and I wanted to make a really important distinction here between CT, X-ray, MRI, and ultrasound. When you do an MRI, or when you do a CT, or indeed an X-ray, all the digital information, all the diagnostic information you need is within that data set that you've acquired. So if you've got an MRI scan, you've got a volume of data, and all the diagnostic information you may need is within that set of data. This is why a technician can take the MRI and then a radiologist can read it. So the challenge in these type of imaging modalities is going into the data set and finding what's of interest, be it a biomarker, be it finding an abnormality in physiology or pathology. This is very different in ultrasound. So there are already solutions today in medical imaging, in X-ray, CT, and MRI that, for example, prioritize a list of reporting. A radiologist sees a list of X-rays done from the day before, and the radiologist comes in at 9 o'clock in the morning, and she may examine the 9 a.m. X-ray and then the 10 a.m. X-ray and so on and so forth until she gets to the 5 p.m. X-ray. But what if that 5 p.m. X-ray shows a pneumothorax? Okay, so what an AI algorithm can already do today is prioritize that list and show the radiologist the pneumothorax X-ray first. It's not doing diagnosis. It's not stopping anyone from doing anything and providing a good report to everybody, but the radiologist will see that high priority image first in her working day. It can be used to highlight suspicious areas, help take measurements, or indeed suggest diagnoses. Now, ultrasound is very different. When you do ultrasound, if you don't scan over the area of interest, then the data are not there. If you're doing an ultrasound scan of the liver and you miss a bit of the liver in your ultrasound scan, that data is non-existent in any shape or form. Therefore, no matter how clever your AI algorithm is, it's not going to be able to tell you that there's a problem in the left lobe of the liver if you haven't imaged that left lobe of the liver. So it's really important to think of this distinction when you think about MRI, CT, and ultrasound on the other hand. And therefore, in ultrasound, it's really a different problem that you're addressing, not just because it's real time, but also because of this peculiarity of it not taking a whole data set. So here, the AI is going to help us to ensure that we are capturing consistent image data set, ensure that that data set is complete and of high quality, perhaps give us instant quality assurance, and then confirm anatomy or detect abnormalities. And we'll be talking a little bit about that, and also speed up the scanning process. So in terms of workflow improvements. Sorry, I'm still getting to grips with this clicker. So what do we need in order to build AI algorithms, be it in ultrasound or in anything else? Well, we need big data. We need lots and lots of images. In medical imaging, we need a really importantly clinical understanding, and we've talked a lot already today about the interaction between clinicians and industry to achieve this. And of course, we need our experts in technical know-how to create the network topology that we need and avoid things like overfitting illustrated in the bottom there. So let me just give you one example. Here we have an abdominal circumference. This is an ultrasound image of a baby through the abdominal, through the abdomen. On the left panel there, we have a manually annotated abdominal circumference. On the right, we have one that was annotated by a computer after a little bit of training. And on the graph, what we're going to show is that how with more and more data and more retraining, this algorithm is going to get better and better and better over many cycles to improve. And this is obviously just for illustrative purposes. This has been trained over many cycles. And then eventually you can see that the computer can recognize the image and segment the image, as well as a clinician on the left panel there. So this is how the story goes. And again, thank you. So how can we apply this then to better screening? I've got these numbers, by the way, go up to 5, so you can time yourself the talk. How can we improve screening? Well, screening in obstetrics is really important for all sorts of things. So we screen, for example, for placental location. We screen for growth abnormalities. We screen for presentation of the baby, whether it's cephalic or breech. One of the things we also screen for is congenital abnormalities. These are congenital abnormalities from a very large database of European, from data from Europe. And you can see that we're very good at detecting anencephaly. These are normal detection rates within the population. This has nothing to do with AI. So anencephaly, we're very good at detecting with ultrasound, or severe conditions like bilateral renal agenesis or abdominal wall defects. Less good at things like transposition of the great arteries. These are important cardiac defects, or hyperplastic left heart syndrome, for example, which are heart abnormalities that are important. And they're important because optimizing the care of the newborn when you know such a condition exists is very important. Transposition of the great arteries, for example, detected in 66% of cases, the baby will be born and will be completely fine. Will be completely fine because the duct that connects the aorta to the pulmonary artery is open at birth, and the baby will get sick on day 3, 4, or 5. It will get cyanosed, and if you don't do anything really quickly, that child will die as the duct closes. These are late blue babies, late cyanotic disease. So detecting them antenatally is really crucial to ensure that their care is optimized. How could we then use AI to try and improve things? This is a system from a manufacturer, and what it's doing here, it's recognizing the image and it's annotating those major chambers. So without doing anything, you can just click a little button and it will recognize the image. So I haven't told the ultrasound machine that this was a 4-chamber view. It recognizes it's a 4-chamber view. It recognizes the different chambers. Moving up here to the 3 vessels. This is slightly higher in the chest of the baby. We can see that the pulmonary artery dividing into 2, the aorta and the superior vena cava. And again, I'm just scrolling back here just to get to a slightly better image. It's not particularly good, which is why it's only recognizing they're the right ventricle. Here we have the left ventricle and the left ventricular outflow tract. So the ascending aorta there. So just with a simple mouse click, what the machine is doing is recognizing those images and labeling them for me. Okay. Now, that's great because it's labeling the images. That improves my workflow because I don't have to manually label those structures. But actually, I still need to know how to do the cardiac scan. Otherwise, it's not going to be able to see the thymus, the pulmonary aorta, and the superior vena cava. So this is a system that's available today, and we've been testing this system, and it kind of improves workflow a little bit, but it does have limitations. So for example, if there's a pretty big cardiac abnormality, we'll still recognize the main chambers, even if there's a ventricular septal defect in the heart. It won't tell you that there's a problem. It's just trained for labeling images. And this is going back to what we discussed previously with Alison as well, when we were talking about how AI algorithms are domain specific. They do what you've trained them to do. So this system that's been trained to label images, it will label images or automatically measure images. That can improve your cardiac screening because you're making sure that everything is properly seen, but it won't detect abnormalities. This seems to be randomly spooling forward or backwards. This clicker is quite interesting. This is another system, and what this is going to do, it's going to tick off a little checklist of anatomy. So on the left-hand side there, you can see a whole checklist. So when you're doing a scan, you've got to remember there's about 20 things you want to see, and that is quite a lot to think about while you're screening. So what this system is doing is as I'm scanning, it's recognizing that that's a hand and it ticks it off, making sure that there's a real-time checklist, making sure that everything that should be seen has been seen. And if I try to exit the examination before the examination is complete, a little warning sign will come up that says your examination is not complete. Are you sure you want to exit? Here it's looking at the kidneys. And really importantly, this runs completely in the background. So I'm scanning, I'm freezing the image to inspect the plane that I've looked at. the system has recognized this as kidneys. There it is on the screen as well. And there it is, that little green box getting ticked. But I don't need to press any buttons. This was going back to what Dr. Agrawal was saying, the other Dr. Agrawal, that AI systems need to be unobtrusive. Otherwise, you know, if they're going to cause you to have to click 20 buttons, they're actually slowing you down rather than speeding you up. Now, one thing is to check off, can I take the other microphones out? One thing is to check off anatomy, just to say this is an abdominal circumference. And a different thing altogether is making sure that that image is actually appropriate and of high quality. So what we can do is to have quality markers which tell me that the abdominal circumference is found, there's no kidney on that image, which is how it should be, that the ribs are seen, that the stomach is visible, that the umbilical vein is visible. So it gives you not just the presence or absence of the structures, but it also tells you that the image is of high quality, except for magnification. That's why that little box there is gray. So this is, if you like, the next level up. And you have quality metrics for everything. So here are the nose and lips. I don't know if you can see, that's the tip of the nose, the little nostrils of the baby, and the lips as if the baby was kissing the screen. That's what that image shows. And you can see there, you can see the nasal tip, the upper and lower lip, and that the magnification is adequate. So let's see how this works in practice. This is a profile of the baby. And when I freeze the image, it's showing me that all those markers are green. So showing me that this is an adequate image. This is another example of the lips and nose. Look what happens as I spool back and forward. Can you see those boxes going gray or green, telling me, yes, the quality is good, or no, the quality is not so good if you return backwards a little bit. So all the ultrasound machines have a little action rewind button. Here I'm looking at the orbits of the baby. Again, both orbits are visible, and so on it goes. So you can clearly see how this could ensure that the sonographer is getting that, what we talked about, making sure that the entire data set is seen, number one, and that the entire data set is of a high quality. And through that, hopefully, we should then also improve the detection of abnormalities. This system is not designed to detect abnormalities. This system is purely designed to ensure that you've got an adequate scan record and that the quality of the images is good. And we believe that if you do that, if your images are good and if you've got a clear view of the kidneys there, for example, of the abdomen there, then if there was an abnormality, you would be able to detect it. Now, what we've done is looked at the accuracy of this system. And it's really important when you do studies in AI, in ultrasound, or in any other field, to realize that if you ask two radiologists, and we all know this from clinical practice, if you ask two radiologists to give you an opinion on the same scan, you rarely get exactly the same answer, right? If you ask two radiologists, you usually get three opinions. So what you need to check is, first of all, what do two experts believe between them? So how much do they agree? Because a computer system can only agree either with one expert or the other expert. It can't agree with both if the two of them disagree. So this kind of sets the baseline against which you are going to test your algorithm. So this is for scan completeness. Is the scan complete? They agree pretty well, 96% of the time. But if you look at image quality, they only agree 84% of the time. That means in 16% of cases, one expert says, this is a really good image, and the other expert says, nah, not so good. If we compare that to the AI system, you can see that the AI system agrees with the expert 95% of the time, and the AI system agrees with the expert 84% of the time. Or in other words, if you just look at the data, I would not be able to see if it was an expert experiment or an AI system expert experiment, or a little bit like a Turing test. You could not tell the difference between the AI system and the human, or in other words, the AI system performs as well as an experienced sonologist. Now, we've talked a little bit about detecting abnormalities, and there's lots of papers out there. Ashok, you showed one on cranial defects. I just picked one from the literature, which I picked it because it's in Nature Medicine and it's in cardiac defects, and that's important. And this is the name of the paper. And I'm going to show you why I think that it's not correct that this network provides expert level prenatal detection of complex cardiac disease. What they did is they fed into an AI algorithm lots of normal images of the heart and an equal number of abnormal images of the heart, and then they tested it in a separate data set. The training data set from a center in San Francisco, the testing data set from a hospital in Boston, so quite nice, different hospitals. And they said that the AUC was 95%, which sounds really impressive, and it is really impressive, it's really good. I want you to concentrate on this green line, which is the line for the 4-chamber view, which is the most important one for the detection of the disease that we care about in this particular slide, which is hypoplastic left heart. You can see the C there. That tells you that there's a whole bunch of these ROC curves in the paper, but this is just the one. So an ROC curve shows you the detection rate on the y-axis and the false positive rate on the x-axis. And what's important when you think about clinical implementation of screening is not just to look at the AUC curve overall, but actually to think about what does this mean in practice? What does this mean in practice is that to achieve a really high detection rate of say 95%, you would have a false positive rate of 20%. Now, I don't know about you, Ashok, but would you tell 1 in 5 of your women your baby has a hypoplastic left heart? This is terrible. You can't do that. Hypoplastic left heart is a really rare disease. You can't have a false positive rate of 20%. Yes, the detection rate is good, but it's got to be matched with a false positive rate that is sort of adequate. And even if we go down to a false positive rate of say, 2 or 3%, which is still quite high, that would mean that in my hospital every day, we scan about 100 women a day, every day we would need to send 3 women to a cardiologist for the query hypoplastic left heart. And we would be detecting only about 85 to 90% of cases. Remember also that I would send another 2 or 3% of women for a query TOF, which is ROC curve A, and another 2 or 3% for a VSD, which is ROC curve B. So all these false positive rates are adding up. So if I do the whole program, I might be sending half my women up for a cardiology scan, completely unsustainable. So while this is a really nice paper, I don't want to dish it, I think the main problem with it is actually its title. I don't think this is expert level agreement. I think this could be a first level screening tool potentially, but even so needs to get much, much better. And the solutions that Ashok showed this morning on fetal brain abnormalities have similar problems. So we're getting there, but we're far from implementable diagnostic tools, I believe, right now. The next question is whether we could use some of this technology to help global health impact, supporting really better care in underserved areas. And we're all here today, part of the Colopus project, which I'll just mention briefly. The WHO says that all women should have a scan for a positive pregnancy experience. And the main components of that are to ensure cardiac activity. Is the baby alive? Now, this might sound really basic, but the way that fetal viability is detected in a lot of countries is with a toilet roll holder that you put on the abdomen. It's called what's it called? Pinard's stethoscope. Does that still exist? We have it in some museums here and there. It's literally a tube that you put on the abdomen and you put your ear against it. And yeah, and you pretend that you've heard the fetal heart after a long, long time. And if you haven't heard it, usually you hear your own heartbeat in your ear as you get more and more anxious that you're not hearing it. And your heart rate reaches fetal levels of 120. And then you reassure the mother, it's okay, I'm sure this baby's fine because I can hear a heartbeat. Okay. Basic ultrasound should at least be able to detect cardiac activity. And there are a lot of women, so a lot of stillbirths that are coded as intrapartum stillbirths actually are nothing of the sort. They are antepartum stillbirths and the diagnosis was never made. The fetal number, which is pretty important to know if you're carrying twins or not, a chronicity of multiple pregnancy, if you have it, gestational age, and that relates to fetal size, and presence of major abnormalities. Placental appearance, I was surprised the WHO put that so low because a low-lying placenta previa, is a major cause of maternal mortality worldwide. And I think that should be a much higher level objective. And in later pregnancy, we also care very importantly about the presentation of the baby, whether it's head down or not. So why is this scan recommended by WHO not in place? 2 reasons. Equipment reasons and people reasons. Equipment, it's not there, it's too expensive, or it's there because an NGO bought it and it's in the corner under tarpaulin because no one knows how to use it, or because it broke down some years ago and there's no technical support to fix it. And we've all of us who've worked in the field seen this in action. And on the other side, we have a lack of trained staff and a lack of training programs quite a lot of the time. So can we use AI to help with that? Given that now, increasingly, we have low-cost solutions and quite robust little ultrasound systems that are even on your iPhone. And the Calopus protocol, and Alice will be talking a little bit about the sweeps, aims to do this with just some really standardized ultrasound sweeps to get some very basic information about the pregnancy. This is not to replace a good ultrasound. This is to replace no ultrasound. That's really important. So if you do a single sweep of the abdomen, you can, with clever systems, detect different things, and you can see how that could lead to some sort of interpretation of that image. One thing is detecting those things, but the other is really importantly to integrate that information into what I would say risk assessment algorithms. So it's not just to know whether the baby's breech or not. If a baby's breech at 28 weeks and the mother's not in labor, that's completely fine. If the same baby's breech and the mother is in labor, then it's important information. If the baby's breech and it's 38 weeks, that's also important information. So depending on what you find, you need to integrate it with clinical parameters such as gestational age or status of labor before you can make a decision. So it's not just about finding the piece of information that the AI can give you, it's really cleverly integrating that in some sort of decision-making algorithm. And another tool that we have is the tracer tool. I'm really proud that we got a high commendation from the engineer. Again, this is collaborative work with Alison and her group, and it's within a project called Precise, which is a large biobanking project. And when you create a biobank, it's really important to know what the gestational age is of the baby, because most serum markers in the maternal circulation change with gestation. So if you measure something at 18 weeks and you measure the same thing at 32 weeks, you'll get a very different answer. So unless you know the gestation, very difficult to interpret those markers. So the pure aim, there's a single aim of this simple device is to estimate gestational age. So we've created this low-cost probe that you can see at the bottom there. It's made by a Chinese company called Conted, and it's linked to a very cheap tablet computer made by Huawei. We've gone for the cheapest things we could find in order to create a system that's less than $1,000. I think it's about $800, is it, Alison? And essentially, what you do is the system recognizes automatically the head circumference and the transcerebellar diameter, which maps very closely to gestational age, and very simply measures that. Here is just a little video showing how that looks like. Really important, this is showing those white and black bars, is showing the quality of the video. So it's really important that there's an underlying quality assessment of the video that happens in real time. Now, I'm talking about clinical implementation. What happens if you date pregnancies accurately? Okay. Now, dating pregnancies accurately is important for individual management of women, but it's also important from a public health perspective. So look at this graph. On the x-axis, we have gestational age at delivery, and on the y-axis is just the frequency distribution. So you can see that most women deliver around 40 weeks. Now, in green is the gestational age distribution if you date these women by last menstrual period or other clinical parameters such as fundal height, whatever you have available. So that's the distribution of gestational age in the population dated clinically. And in red is the distribution of the gestational age at birth when you date with this tracer device. And what you can see is that on average, the gestational age is pretty much the same. The peak is more or less in the same place, but it narrows very much the accuracy. Does that make sense? So it looks like in the population, you're reducing the rate of prematurity from 16% down to 9%. We haven't done anything. We haven't intervened. We haven't measured the cervix or given progesterone or anything like that. Obviously, we haven't actually reduced the prematurity rate. These babies are exactly the same babies, whether you date them by one method or the other. But in terms of the count of the burden of prematurity in that population, we know now that the burden actually isn't 16% at all, which is what everybody was jumping up and down about, but it's closer to 9%, which is a much more reasonable risk of prematurity in that population. So you can see how these data can help not just for the care of the individual woman, but it can also inform policy, because obviously if prematurity is not as big a problem as you thought it was, that's important to know. Now, Angela is working in Kenya, and Angela's really kindly joined us on Zoom today. So Angela's going to tell us about her experience of using this system in real-world settings. And she's also done a really nice survey where she's talked to patients, mothers and mothers-in-law quite often, and clinicians. Angela, are you there?
Yes, I am.
Can we switch over to Angela, please? Angela, thank you for joining us.
Thank you.
Angela works in Kilifi, which is a beautiful town on the coast of Kenya. Angela, over to you. That is open the challenge. Do you have, yeah, just give her a little red. I left my phone over there. So the plan was for Angela to come in and tell us a little bit about Tracer. and then for me to carry on with some of the other issues. But in the interest of time, what we could do is, while we get Angela back, we'll interrupt the flow a little bit, but that's okay. In the interest of time, why don't I finish, and then we can come back to Angela a little later. Is that okay? So can we go back to my slides, and if you can communicate with Angela in Kenya about that. Can we go back to my slides, please? Is that possible? Sorry about this. It was all very well planned, but we were not counting on. Just go to, yeah, brilliant. Thank you. So we talked earlier today about biomarker discovery and using imaging for radiomics, if you like. And I just wanted to give one example of this. We've already seen the nice work that Ashok showed from the lung maturity and the cervical perspective. But this is another project. This is again going around gestational age estimation. We've thought about gestational age estimation a lot in our group because it's such an important aspect of care in a lot of these settings. Now, usually you estimate gestational age by LMP, but in a lot of places the LMP is unknown, or the mother may not even have periods because of malnutrition, or she's been breastfeeding, or she was recently pregnant. All sorts of errors occur. So the next best way of dating is by measuring the crown rump length. You do that 11 to 12 weeks. The problem with that is most women don't come so early to the attention of caregivers, and often they will come later. And when they come later, what you do is you measure the general biometry of the baby, the head, the femur, the abdomen, and you try to estimate the gestational age from the size of the baby. That obviously has an intrinsic problem within it. If I see someone who's like that tall and I say, you're 4 years old because this is what you measure, or if you're that tall, you're 2 years old, obviously that has an error, because if a kid is really tall, you will overestimate how old they are. And if they're malnourished and they're stunted, you will underestimate their age. With age, it's easier because pretty much everybody knows when you were born. But this, with gestation, it's not so easy. So if you have a small baby, because it's growth restricted, you will underestimate the gestation. And if it's a big baby, because the mother has diabetes, you'll overestimate the gestation. So this is an intrinsic problem that you have with estimating gestation based on biometry. And the other problem is that, especially in late pregnancy, a lot of the growth parameters flatten a little bit, which means if you have a measurement of, say, 300 millimeters, on average, that baby will be, 34 weeks or whatever it is, yeah? But look at the range. It could be anything from down here all the way to up there. So the range is really wide. It's about 6 weeks. And this is a real problem when you try to estimate gestation. So what we thought is, could we use how images look like to estimate gestation? So if I showed you a head from a 15-week fetus or from a 30-week fetus, and I showed you no measurements at all, you would be able to tell me which is which because they look different. So what we did in this project was to feed in the individual images and then estimate the gestational age based on these individual images, but then also put the three of them together. And we did this after really carefully removing all information from the images, all size information. The calipers were not there. And even there's a little ruler on the side of the ultrasound machine, which tells you the size. Even that was obscured in order to not allow the algorithm to cheat. We developed this in this set here. This is head, abdomen, femur, and all together. And then tested it in an independent test set, again, head, abdomen, femur, and all together. And what we can see, and this is still preliminary to some degree, what we can see is that the gestational age estimation, purely based on the image characteristic, is really very good. So these are equivalence curves, so the ground truth gestational age on the x-axis, the estimated gestational age on the y-axis, and you can see that they concord very, very well. And I remind you that this is not based on any biometry. This is purely based on the image characteristics. So in summary, deep learning is really good at ultrasound image pattern recognition. I think sometimes is as good as humans, if not better sometimes. I think AI systems are already there in real-world applications that support quality control during screening and automate recognition and measurement of basic ultrasound. I've shown you some solutions today. Imaging biomarker discovery using AI is starting for gestational age. It's available in very specific conditions such as estimating lung maturity. And at this stage, I think anomaly detection still needs a lot of improvement before we have real-world systems. There's lots of other areas which I haven't covered today, using AI to analyze data, using AI to guide you when you detect an abnormality to look for the next abnormality, such as in sort of ultrasound dysmorphology, if you want to call it, but also in biomarker discovery and drug development. We can't cover everything today, so we thought we will end it there. And I'd like to thank, of course, the entire group on whose behalf I'm talking today. Thank you.
Aris, I'm back if you still have time for.
Angela, we have you back.
Yes, we do. I'm sorry.
No, don't worry. It's absolutely fine. Angela, what I've done is I carried on with my talk so that we didn't have the interruption, and then I'll let you continue with your talk. Thank you so much.
Thank you, Aris. And thank you so much for the opportunity to speak about our work, which we are doing in Kenya. I've had the pleasure of working with Aris and Alison's team from Oxford, and also with a large collaborative group, the Precise Network. And it's through this network that we are conducting a pregnancy cohort study in Kenya and other parts of Africa. And this work on gestational age assessment is embedded within it. So for this presentation, I'll be talking about how we use qualitative methods to better understand the needs of the actual users of the gestational age assessment tool, but also to understand what their perceptions towards the tool would be. So the innovation, Aris has already introduced what Tracer is, and this was designed for a setting like ours, a resource limited. As he's mentioned, the scale is limited, but also the devices for ultrasound are limited. So before going further into understanding their acceptance towards it, it will be important to understand, do the intended users actually feel a need for something that
Because Kenya has turned very good telecom back in India. Let's give Angela 2 to 3 minutes and try one more time. Thank you.
We'll take questions while we are waiting for Angela, so we can save time.
Yes.
From the audience. Yes, please.
Is there any shortcut by which we can recognize that a paper is something that we need to look at very critically as opposed to just accepting blindly?
I don't think there is. I think interpreting data within a paper, even, because One of the biggest problems is not the data that are shown in the paper, but the data that are not shown in the paper, just apart from the interpretation of what is shown. So in this particular case, what I've, and if you're talking about the cardiac anomaly screening one, what I've shown you is I've interpreted the data that they've shown in a slightly critical way, I admit, and I'm very impressed with the work that they've done, but we need to move away from saying it's this accuracy or that accuracy and saying, okay, it is 90% sensitive and 93% specific. That those numbers sound good. Now we need to step back and say, what does that mean in my clinic? What does 90% accurate mean in my clinic? What does 93% specificity mean in my clinic? And then start thinking through those issues like we did in that example I showed. Thank you. Angela, I'm so sorry we're having connectivity problems. I just wonder if it might be worth switching your video off if that improves the bandwidth, although we would love to see you, but I just wonder whether it may just improve things a little bit. Go back to perhaps
just going back to the question of specificity and sensitivity. But when we talk about this, don't you want to think about what will be the downstream of things? So for example, 1 in 5 we misdiagnose or has to be referred to somebody else. But this may not be the case for all the findings out there. And this might be okay for some of those. Don't you consider those? At least from the deep learning point of view, we don't really consider what happens when the accuracy is low. But what you're pointing out is that what happens after that is an important point.
Yeah, absolutely. And I think like ultrasound is a tool, or like, any clinical thing that we do is a tool. AI is a tool. And when we use a tool in clinical practice, it's always absolutely crucial that we understand, or it's actually mandatory for us clinicians to understand what are the benefits of that tool and what are the limitations of whatever tool that we are using. All tools that we use have limitations. And as clinicians, we must never forget the limitations, because those are going to be what dictate our performance, if you like, as clinicians. So yes, so this is one limitation, and it also depends on what is it compared to, right? So, how is your wife? Well, compared to what is the old joke. The same is here. The detection rate is at 90%, is at 95%. Well, compared to what? So in the UK, where the false positive rates in the screen population are quite low, it would be nonsensical to implement such a system. But there may be settings where actually it's okay because it's better than the current state of the art.
A question. I was very interested in the, I think Angela's back.
Yes, I am. Would you like me to continue, Aris, and give it a last try?
And Angela, yes, please do. And with your permission, if it doesn't work, I may just run through your slides here because they do have an important message.
That's okay, Aris. Thank you. So when we began this work, we did spend some time just asking ourselves, do the healthcare workers, do the women at the site where we're working, do they consider that there is a need for gestational age assessment, or is there actually a problem or a challenge that they're facing with gestational age assessment? So for this study, we use qualitative methods. And in this, we spoke to women not just the pregnant women, but also their spouses or their male partners, and also their mothers and mothers-in-law, who are a key decision maker in pregnancy in this population. And we also spoke to the healthcare workers as well as the managers. And these were healthcare workers involved in provision of antenatal care and maternity care. So we asked what they thought about gestational age assessment, but also did they find this innovation feasible and acceptable for their setting. So we did work with a big team, a multidisciplinary team, and in this case, we worked with social scientists as well. But we also had researchers from Kenya and researchers also were international. And this was a very good opportunity for our team also to begin conversations around the innovation, and it formed a form of community engagement because we were able to introduce the idea to the nurses and the healthcare providers and hear from them the very initial views even before we implemented the study. So the setting, our study was done in Kilifi County, which is on Kenya's coast, and we chose two facilities. One is a rural facility and the other is an urban facility. The rural facility is a health center that had, at least at the time we did the study, no ultrasound service whatsoever. So women did not get ultrasound, and any who needed ultrasound was referred to the urban center. And the second site was a hospital in an urban, peri-urban center. And here ultrasound was available, but was only used for complications in pregnancy. The participants of our study I've already mentioned, and I just want to highlight again that there was a special group here of the older women because we knew they're the decision makers regarding antenatal care in this population. The health providers we spoke to were quite diverse, both in their skills and even the exposure to ultrasound. There were nurses who'd never observed an ultrasound procedure before, and we had sonographers included. We had obstetricians who did do complicated ultrasound as well. So for data collection, we used focus group discussions and in-depth interviews. And because we had not yet started to use this technology in the clinical setting, what we did was a simple video role play of how this tool could be used in the antenatal care clinic. So we had a nurse and a patient model how the tool would be used. And we had a 4-minute video, which is what we showed to the participants prior to the data collection sessions. And in the interview, we discussed what their current experiences were with GA assessment, were they facing any challenges? And then we asked them specific questions about tracer. What were their initial reactions? Did they think this could work in their facility? What difference did they think it could make? And would they be confident in the results that they got? We also asked them some questions about implementation, like where did they think was the best place for it and who was the best provider to give it? So I'll discuss some of the findings of our study as well as discussing them as we go along. And the first finding that was important was indeed there is a need for better gestational age assessment. There was lots of discussion around how LMP is unreliable in this setting. Women, of course, would forget, but some would simply just guess. So the nurse wouldn't know it's an uncertain LMP. And then when different methods were used, like LMP and fundal very often that was conflicting and left everybody confused. Ultrasound was available, or that was known to be available in the settings where it was, and people did know that this was reliable, but access to it was limited. And even when moms were sent for it, not always would they be able to access the ultrasound. But perhaps even worse was that there was fairly haphazard use of ultrasound, ordering several ultrasound scans, ordering ultrasound quite late in pregnancy to resolve gestational age conflict. So confusion, even after ultrasound was used, was quite common. But now regarding tracer itself, the initial views that we got were overwhelmingly positive. I mean, women felt this is great. This is something that we would love to have. I would be able to see the baby. I would be able to at least know the baby is doing well. And I'll talk about this a bit later, but that they would also know the date of delivery, the expected date of delivery, and would be able to plan around this. But they would also feel confident in what their provider tells them. And also, especially for the rural center, they would feel more time is saved without them having to go all the way to the urban center for ultrasound for gestational age assessment. Healthcare providers, of course, felt this would really boost their confidence when they're giving feedback to patients and their self-image. Providers also felt that this would change how antenatal care work and that there would be less confusion. What am I dealing with here? Is this the gestational age or not? And that they would feel more confident knowing that, yes, I'm certain this is the GA that I'm giving to this patient. And providers in the rural site actually, in the urban site where there was one ultrasound service, felt that there would be this significant reduction to the workload at these few ultrasound facilities that usually were quite understaffed. Here we have a comment from a healthcare worker in the urban site. So while ultrasound is present, it's serving all kinds of patients in the hospital. And then when you now add the burden of obstetric patients, then it's quite difficult to attend to them all using this one skilled provider. So what were the perceptions of the technology? In this case, the AI or the automation into the measuring this. So women were quite happy with it. And for them, they really did emphasize the bit of seeing this image. And this was a major contributor to their trust. Women said, because I'll be watching from the tablet as I'm being examined, that will make me confident in the results. And I think Aris has just mentioned, this is really being compared to the PNAD, where the nurse would be listening for herself and hearing the magical fetal heartbeat. But at least here, the mother can see something that adds to her reassurance. And that the automation was viewed favorably. Healthcare workers felt that this machine would be less susceptible to human error compared to my ears listening into the fetal heart rate. And many women actually, or even the male partners actually mentioned this, that the use of technology felt like an improvement to the quality of the healthcare, and this would make them think that the care they were receiving was better than what they had before. But there was some mentions of sort of preconditions that people gave towards accepting this. I'd say, okay, yes, I think this is awesome, but. So there was quite a bit of discussion on this, and many of them said, I think I'd need to test this device first before I know how good it is. And healthcare workers would say, well, I'll compare what it tells me to what the formal ultrasound tells me. But more concerning is community members say, I'll wait till I deliver and see how accurate this machine is. So this is where they would actually compare the EDD with the actual delivery date, which may not actually be a good way to test the device. And then for some said, well, I think I'll accept it, but give me some time. Here's a quote from a doctor from the Urban Center who says, well, sounds good, but give me some time to test it. So let me allow you to read the quote for yourself. And another quote again from a healthcare worker. This is actually a healthcare worker who has experience with ultrasound, but doesn't usually use the measurement of the cerebellum, which is what we use in tracer in this case. And he says, well, this sounds new, so maybe I'll compare, and then I'll take some time to assess it before I can then accept the tracer. So interestingly, the hesitancy was more common was less common actually in the rural site. Almost everyone in the rural site was like, yes, bring this is what we need. And perhaps because there was no ultrasound service there, and they really did have challenges with referral for ultrasound. And the urban site, there were staff with higher technical skills, and they were a little more hesitant in accepting the technology. They desired perhaps more technical information to be given to them, had more questions, how does this work? And also desired a bit of a test period. When looking at the feasibility, the approach to how should we set this up, and the ideal and the most recommended approach was that this should be provided at the antenatal clinic by the antenatal clinic nurse and should be given for all pregnant women. We also looked at training in terms of implementation, and in this case, many of the healthcare workers, in particular the nurses, felt that, yes, this is something I can do, just train me and I'll be able to do this and I'll be able to offer this service to women. And many of them felt just some short training, train me on the job and I can do this. But those who are more skilled or more exposed to ultrasound were a little more hesitant about this and felt, I think we're going to need a lot more training than what it seems like. Healthcare managers were an important group that we interviewed, and these ones had unique concerns about the implementations. And they were quite concerned that if this is started, it's important to make sure it's consistent, it's always available, and that we can do this for a longer time. Will we have supplies? Will we be able to maintain the equipment? And this is a typical day at the clinic. Actually, this is not a typical day. This is a low turnout day at the antenatal clinic. So nurses, of course, would be concerned, can I scan all these women alongside every other thing I'm doing for antenatal clinic? So this was a concern by mostly the managers. And then the question is, should we apply this selectively? Should we maybe say, let's only do this for women where we are uncertain of the gestational age? Or should we only do this in facilities where ultrasound is not available, as opposed to where ultrasound is already accessible to most of the women? Misconceptions were quite common, and it's quite important that we mention these. And these were by both community members as well as the healthcare workers. Many really overestimated what tracer could do. This is a simple tool that was developed primarily for gestational age assessment, but also did show the heartbeat. But many believed that this was, complete assessment of the baby, and this could even replace full ultrasound assessment. This is concerning, as well as the misunderstanding that EDD, this is going to magically predict the exact day I'm going to go into labor. This was a common misconception by the community. This is a comment from the male partners and a comment from an antenatal care nurse showing the misconceptions around tracer. So just briefly, from the views that we got, we felt that the proposed structure of implementation for tracer would that it should be used in the settings where universal access to ultrasound has not yet been achieved, despite it being recommended, and that it should be provided ideally by nurses. These are the ones who are already providing antenatal care, and it should be given ideally for all women, but that referral pathways should be maintained. For women who we feel need full ultrasound assessment, this should continue. Clinical assessment, clinical triage, and all the other processes should be maintained so that women who need full ultrasound assessment can still go for full ultrasound assessment. So in summary, there is indeed a need for better gestational age assessment, and AI-enabled ultrasound innovations that will meet this need, I think, will be acceptable and feasible in our settings. We need to be cautious about the messages that we give to the users and even to the community, because the meaning of GA is not always clear to them. And also the role of this tool is for GA assessment and should not replace complete assessment, both clinically and further ultrasound where this is needed. I think another thing this study shows is how we've used different methods, in this case, qualitative methods, which are not our comfort as clinicians and radiologists, but these methods have helped us to evaluate these innovations. And in this case, we've actually evaluated it before rolling out. So we are able to use this early information to design how we will roll out the innovation as we go. Thank you very much. I'd like to thank all these people as well as the community in Kilifi for the opportunity to do this study. And my apologies for the horrible internet connection today. Asante.
Can I just wanted to comment to say how glad I am that we waited for your talk, Angela, because it's absolutely clear and really important, this concept of ensuring that we're doing it the right way and asking parents and healthcare workers what they think of such innovations.
Shinjini.
He was asking, have you ever asked the stakeholder whether they are happy with this, getting a message from a new novel method? And I think this is it's very good analysis of what the actual people were delivering it and getting the device examined on them. So thank you very much. That was really interesting, particularly for people like us who are dealing with patients in the peripheral regions.
Okay. Question over there.
Is Angela still there?
Angela, are you there? Just please confirm.
Yes, I am.
Lovely.
Okay.
Thank you so much for your excellent presentation. I was wondering if you had any advice for settings where you particularly have sort of doctors and things who do a lot of the scanning and perhaps want to hold on to as many things as they possibly can because of financial benefit. How have you made it more acceptable for low-cost devices like this to be used by midwives or traditional birth attendants, people who wouldn't normally perform these sorts of tasks, so that technology can become more available to the masses?
So I'm sorry, I didn't hear the first part of your question, but I just had the last part where you mentioned traditional birth attendants.
Yeah, so it was, how do you often ultrasound and things like this are very much performed by doctors and people with more training who aren't particularly keen on technology like this being rolled out to traditional birth attendants or midwives because it's taking work away from them. And I'm wondering if you've got any advice about how these sorts of technologies can be viewed more acceptably by doctors or sonographers who might otherwise prefer to do all the work themselves.
That's a very interesting comment. Maybe I'll comment and then Aris can come in after that. So it would be very interesting to speak to the community health workers. In Kenya, we have community health volunteers who are similar to like the ushers in India. And in this study, we did ask the nurses what they thought about us giving them the tool to the hands of the community health volunteer to assess the gestational age themselves. And there was a very universal no from all healthcare workers, like, no, this does not belong in the hands of the community team for different reasons. Well, maybe said they already have too much on their hands. And then of course, for their bigger reason that they don't have any medical training, and that it will take quite a bit for them to interpret what they see from the image. However, we did not get a chance to speak to the community health volunteers themselves, because I think that would have been more useful. I don't know how to advise whether this is something to do, but I know there are planned improvements on the app that perhaps will make it easier for people to learn how to use this app and to give feedback as the person captures the images. And these might make it very easy to train. And who knows, then this could get us to the level of the community health volunteer with no medical training being able to capture this. I'm also quite keen to listen to the Kalopa's presentation and to see whether they are closer to the unskilled health provider, because that would be a good opportunity also to test how to perform in their hands.
Thank you very much, Angela.
Thank
Give
you.
it to Ari to see if anything he wants to. Okay, so nothing more.
Can
Let's
I
say.
also ask Aris a question? Can I ask Aris a question as well?
Yeah, sure. Please go ahead.
So this is really, I love the work that's been done on the gestational age estimation from the images themselves. And I'm sort of wondering, what's it going to take to get technology like that into clinical hands, so we can actually.
Well,
use
you
it?
know, I mean, it's the same kind of stepwise pipeline, if you like, that we've been discussing with Tracer. You know, you train the algorithm within a university, you write the code, you implement it on a tablet. And in that particular case, we worked with a company in Oxford to develop the application and to make it work. And the same needs to happen with the Kalopus work that we've been talking about. The same will need to happen with that particular algorithm. So it is probably the thing that keeps both Alison and myself most awake at night, is how do we transform some of the work that we've been doing within the university into tools that can be used in the field. And it's not easy for the many reasons that we've already talked about, including regulation and ensuring that these systems are appropriately dealt with through FDA approvals, for example, but also in making sure that commercial enterprise is interested in that, because low-cost solutions have very low profit margins and may not be high on their agenda for implementation. So that's a big conversation. I guess short answer is I don't really know how we do it. We're trying to figure it out still.
Thank you all. So we'll close this session, and thank you so much, Angela, for your wonderful insights on real-world implementation. Thank you.
Thank you.